Hello, my name's Lindsay McElroy. I'm part of the professional development team at the Royal College of Nursing. This afternoon, I'm going to give you a short session around recognising and responding to deteriorating patients. As you know, it's something that's very topical at the minute with the current situation we're in with the COVID-19 virus, and particularly some of our very elderly and vulnerable people may be affected in the population. And they're sometimes then the most difficult people to pick up whenever they do deteriorate because they may have some communication problems. So I'm going to take you through what we intend to cover with the session. First of all, we want to recognise when patients or clients in your care are deteriorating and really ensure that patients receive safe and effective care is what we're trying to achieve. We'll look at the need for early recognition of the deteriorating patient. We'll look at the signs of deterioration. We'll evaluate how we record and report deterioration using appropriate pathways as per your local policies. The demonstration at the end of how to assess patients or clients who may be deteriorating using the ABCDE approach we will just talk through for the sake of brevity this afternoon. Okay, so what we do know is that whenever people do deteriorate and there are critical events in hospital, that usually there were significant changes in the patient which could have been detected, and usually those are related to abnormalities of the airway, the breathing and or the circulation. Nurses' ability to recognise and respond to signs of deterioration are vital to patient outcomes and preventing or minimising any major adverse incidents or adverse events. So we need to pay close attention to people's ABCs, their airway, breathing and circulation, because essentially if we don't and somebody has an issue with one or all of these, then that can unfortunately lead to the patient's death. We know that skill mix is an issue. We know that higher nurse-patient staffing ratios are associated with a decrease in cardiac arrest, pneumonia, shock and death. And that came out of the Francis report on the mid-staff's inquiry back in 2013. And we know that our staff shortages have not improved significantly since then, and that we are still operating with skill mixes that are poor and staff shortages that are threatening the actual outcomes for our patients. So what we do know is if we have the right skill mix and the right patients, that adequate patient monitoring and assessment are critical to preventing adverse outcomes. So more nurses equals better monitoring and assessment. We know also that there are a few things that will impact on us picking up the deterioration of our patients, and these are some of the important areas. We know that lack of consistent clinical observations can be an issue, so if OBS are due to be done at a certain time, they need to be done then, and again, sometimes staff shortages and skill mixes mean that those things don't get done when they should be done. Lack of nursing knowledge and skills to interpret signs of clinical deterioration. So that's lack of education for our nurses. The better educated our workforce, then the more confident they are about making decisions and about thinking that they're confident in their ability to call for help whenever they need to. Organisational communication processes can be an issue as well. We need to know who to contact, when to contact them, and how to contact them, and how to get them to actually come out whenever we do contact them. And sometimes failure to effectively communicate deterioration means that we don't get the appropriate help whenever we need to. Also, there's a thought that lack of non-technical skills is also sometimes an issue. And by that, what I mean is that we rely sometimes a lot on equipment. We maybe don't rely as much on our senses. So we need to be thinking about what we're looking at, what we see, what we hear, what's the patient saying, what noises are they making. We have to use our noses sometimes as well. And we also have to feel our patients and put our hands on them and see if they are cold, clammy, hot, etc. So non-technical skills are important as well, and we can't forget about those. Clinical signs then of the deteriorating patient. Generally, the clinical signs of any deteriorating patient will usually show progressive physiological deterioration. In other words, their airway, breathing or circulation problems, and sometimes these do go unnoticed by our staff. To ensure that we detect failing patients, many hospitals use the early warning scores, and we use our news charts throughout Northern Ireland in the HSC trusts. We don't have these charts in the independent sector, but they are available on Google. So if you Google, you can get a news charts, because in the ordinary temperature, pulse, respiration charts, we're not able to track our patients and how they're deteriorating or how they're responding. It is better to use a news chart where we can see trends and we can pick up those trends easier, and then those trends trigger an alert. They give us a score and we look at what score we need to act upon. What we do know, as well as use of news, that we need to be able to monitor our vital signs very carefully. So we should be thinking about what is vital, what are our patients' vital signs, and we're going to talk about those a wee bit more in a moment. But quite often our elderly patients have different parameters due to ageing and due to a lot of the polypharmacy that they can be on. What is very important is that if you feel that a patient is deteriorating, make sure that you call for help sooner rather than later. Don't wait for a continued deterioration. Call for help and get the appropriate attention for your patient. I've talked briefly about the news charts for recording deterioration. Because they show us trends of how our patient is reacting to treatment, etc. What we also need to bear in mind is that we need to record when our patients deteriorate. We need to take contemporaneous notes, and we need to make sure that we have been careful and made an accurate record of what is happening with our patient. We all know the old mantra, if it's not documented, it wasn't done. So we have to make sure that our recording is part of the care that we give to our patients. I talked about vital signs, so now we're going to just go through what those vital signs actually are and what should be recorded for an adult patient in your setting. Right up at the top there is respiratory rate. Respiratory rate is vitally important because usually if you have a patient that starts to deteriorate, the first one of your physiological responses that change is your breathing. So if the respiratory rate starts to go up, the alarm bells should be ringing in your heads. What's happening with my patient? Is there a deterioration? Is something happening? It will change before your blood pressure or your pulse will. And the news charts I was talking about earlier, the first vital sign that's recorded on the news chart right up at the top is your respiratory rate. So a respiratory rate that is increasing, that should cause alarm bells to go off in your head. A respiratory rate that's decreasing, then you need to get help for your patient very, very quickly, because it's likely that respiratory arrest is imminent. We also need to check blood pressure and pulse. That gives us an idea of what's happening within the circulatory system. Temperature, obviously very important. One of the prime signs of COVID-19 is a high temperature. Our oxygen saturations need to be recorded. Our level of consciousness needs to be recorded, because along with airway, breathing and circulation, a problem with our neurological system can also lead to very poor outcomes and even death for our patients. We want to know what the patient's glucose levels are. If they're an elderly person, we would prefer that they're slightly on the high side than on the low side. We want to know what the urinary output is, and we can't forget about pain as well. And sometimes if we have elderly patients or people that don't communicate as well as some because of some learning disability, we need to work out, how do we work out whether this patient is in pain or not, and we need to be monitoring them closely. We can use things like Abbey pain scales or assess them according to how they're reacting, whether they're agitated, etc., etc. Okay, so this is just a little bit of revision to identify the normal ranges of our vital signs that we're looking at. I said, first of all, about the respiratory rate. We're going to talk a bit about tachyapnea and bradyapnea, tachycardias, bradycardias, normal blood pressure, hypotension, hypertension, pyrexia, hypothermia and oxygen saturations. And sometimes our normal parameters, which I'm going to put up on the screen for you now, are different in our elderly patients, and we need to be mindful always, of course, as what the patient's baseline actually is, and sometimes their baseline sits outside of the normal parameters that we know of. So here's a quick run through your normal parameters. Our respiratory rate should sit normally between 12 and 20. Therefore, tachyapnea is a respiratory rate above 20, bradyapnea below 12. Our normal pulse rate is somewhere around 70 beats per minute. A tachycardia is a pulse rate above 100. A bradycardia is a pulse rate below 60. The normal range of blood pressure, 100 over 60 to 140 over 90. Our elderly patients could have much higher blood pressures than this, or if they're on medications such as beta blockers, ACE inhibitors, they might sit with quite a low blood pressure, and they could sit outside of either of those parameters quite easily. So we talk about hypotension as blood pressure below 100 over 60. And it's usually a low blood pressure that will present whenever our patients are deteriorating. So we need to keep a very close eye on that. Hypertension is determined as a consistent blood pressure over 140 over 90. Although we won't treat people for hypertension until it stays consistently at 160 over 100. A pyrexia then, the textbooks aren't all that clear about what we call a pyrexia. Some of them say 37.2, some say above 37.5. What I would say if you're looking after an elderly patient, their temperatures tend to sit quite low. So by the time they have a temperature reading of 37.5, they quite often have an infection brewing. Hypothermia then, a temperature below 35, and our normal oxygen saturation is 95 to 99%, 94 to 100. The difference that we see with our COPD patients is likely to be an oxygen saturation sitting between 88 to 92%. And as we all know, those are the patients we have to be very careful with. If they're deteriorating, we need to be cautious about giving them high flow oxygen. And really we should consider with our COPD patients keeping their SATs between 88 to 92, using a Venturi mask at 24-28% and 3 to 4 litres per minute. Communication. So communication plays quite a large part in some of our adverse incidents and events that happen. So about 80% of them are near misses in hospital. There is some element of poor communication involved there. So what we're going to talk about now is a well-structured process to communicate that's helpful and reliable, and it keeps us objective, and that's SBAR. And those of you working in the trust situation will know SBAR very well and know that whenever we lift the phone to a doctor and say this is an SBAR call, that it means that they are going to sit up and pay attention to us. So for those of you that maybe aren't as familiar with using them, SBAR stands for, first of all, S for situation. So whenever you're communicating, you want to get a doctor to come and see somebody, you have a paramedic that has arrived with an ambulance, you want to say what has happened with your patient. Start with the situation, an introduction of yourself and what's happening. Then move on to the background about your patients. That's any relevant background medical information that will help. There's no point discussing things that happened 20 years ago when they had their appendix out or an ingrown toenail. It's just what's relevant at the minute. Then go on to A, your assessment, your vital signs, and those are your specific observations and vital signs based on your A, B, C, D and E. And then importantly, and sometimes the thing that we forget to do, is to give our recommendation and to say, I need you to come and see this patient. They're deteriorating and I need you to come and see them now. So an example of using SBAR would be, Hello, I'm Lindsay. I'm a staff nurse on the medical admission ward. I'm calling about Mr. Brown. He has been admitted, we think maybe with pneumonia. He has an oxygen saturation of 90% despite high flow oxygen. I'm very worried. So that's your situation. The background, he's 55, previously fit and well. He's had a fever and a cough for 2 days. He arrived an hour ago to us by ambulance. My assessment then is going through your airway, breathing, circulation, disability and exposure, and we'll explain disability and exposure a bit more as we go on. So my assessment is airway. He can say a few words. Breathing, his respiratory rate is 24. His oxygen sats are 90% on high flow oxygen. His pulse is 110. His blood pressure is 160. That's for his circulation. His disability is related to level of consciousness. He's drowsy but can say a few words. He is confused. Exposure is a head to toe check. He's pale and clammy. His early warning score is, and that's if you've been using a news chart. Your recommendation then, I'm worried he's getting worse. I need help. Please can you come and see him straight away? So SBAR is a really useful way of communicating. You need to get in the habit of using it. If you're not in the habit of doing it, it won't come to you easily. But it's a good way to keep you on track, keep you objective, and make sure that you've given all the information that you need to give over about your patient. It keeps you straight. It means you don't jump all over the place from starting off talking about vital signs, moving on to what they came in with. It keeps everything on track, and it also lets whoever you're talking to know that you know what you're talking about and you've done a thorough assessment of your patient. Okay, so during SBAR there, we mentioned our systematic assessment, which is your A, B, C, D and E. Remember your non-technical skills too that go along with this. So along with your A, B, C, D and E, you're also thinking, what am I seeing here? What am I looking at? What am I hearing? What is my patient telling me? How do they feel? What is my touch telling me about them? Is there any particular smell or odours? Is it a urinary tract infection? Is the patient ketotic? So all those senses are as important, and we can't forget about those. Okay, so to start off with airway. To assess somebody's airway, probably the easiest way to do this is to think first of all, how do I know if somebody doesn't have a problem with their airway? And how we know someone doesn't have a problem with their airway is that they're generally sitting up, looking at you, talking in sentences, and looking quite comfortable. And if they're doing that, then you can generally rule out an airway problem. So what are some of the causes of airway obstruction? Things like blood, vomit, foreign body, trauma, bronchial secretions, blocked trachees or laryngectomies, epiglottitis, CNS depression, some of the causes that are out there for you to think about. How do we assess whether somebody has an issue with their airway? Well, as I've said, it's sometimes easier to just work out, do they not have an issue? But apart from that, if you're looking at them, what do you see? What colour are they? Are they comfortable? What do you hear? Are they talking to you in sentences? Can they only talk in gasps? Can they only say one word? Once you've decided that they may or may not have an airway problem, and usually your hearing and your listening is going to tell you an awful lot. With a partial obstruction, you can hear noisy airway and what we call stridor air entry. If it is a complete obstruction, then they will be silent. So how do we treat somebody if we think there's an issue with their airway? I suppose the first thing we need to think about is what's the cause of it. We talked about blood, we talked about vomit. Do we need to use some suction on bronchial secretions, blood or vomit? Do we need to turn them on their side? Anybody who has a depressed level of consciousness, then we're going to have to assume that there will be an impending airway obstruction, and we need to protect that airway doing a head tilt, chin lift, and perhaps thinking about using a Goodell or a nasopharyngeal airway. If you think somebody has a problem with their airway, give them oxygen as soon as possible, use your pulse oximeter and keep them within the normal ranges of 95 to 99. Breathing then. So some of the causes of breathing problems, something like COVID-19 obviously affects our respiratory system, asthma, COPD, chest infections, muscle weakness, falls that may lead to fractured ribs, pulmonary embolus. So how do we assess somebody's breathing? I'd said to you the respiratory rate is often our system that changes first. Our breathing rate increases whenever we start to deteriorate. So the first thing you want to do is check the respiratory rate. And of course the vital sign that we're probably least good at checking is the respiratory rate, and we need to do it properly and accurately. So we also need to know what is normal for our patients. So again, what is their baseline? What is their colour? What are we looking at? What are we hearing? Are they wheezing? Is there any noise as they're breathing? Are they using any accessory muscles to breathe? Are they tripoding, leaning forward on two arms to try and get more air entry? Are their shoulders shrugging up and down? Is their jaw tightening? All accessory muscles to breathe. And if you see somebody using accessory muscles to breathe, it's a very, very bad sign. And again, usually respiratory arrest is imminent. If you think that someone has breathing problems, put the oxygen on, put it on high flow, use your pulse oximeter and check their SATs. If you have a COPD patient, as we said, be a bit more cautious. Use your Venturi mask 24-28% and your oxygen flow at 3 to 4 litres per minute. Circulation, or C for circulation. What are some of the causes of circulation problems? Shock, myocardial infarction, hypovolemia if they're losing blood, heart failure, bleeding internally or externally, sepsis. So how do we assess the circulation? And I think the easiest and most systematic way to do this is to start at the fingertips and work your way up. So first of all, take the patient's hand. What do they feel like? Are they cold? Are they clammy? Are they hot? Move up, check their pulse rate. What's their pulse rate? What does their pulse feel like? Is it rapid? Is it thready? Is it a good bounding pulse? Move on up. What is their blood pressure? Is it low? Is it high? What's happening there? Move on up. Check their temperature. So what's their temperature? Do they have a fever? Because we know that particularly with COVID-19, high fever along with the dry cough is one of the main signs of it. So be systematic, work from the fingertips and work up. At that stage, if you have a monitor to put on the person, put that on if you feel that that's appropriate. So what do you do if somebody has circulation problems? Make sure that they're in bed. Keep them lying flat. You can elevate their legs if they don't have any breathing problems. You may need to think about preparing for IV fluids, and you will also need to get your medical help to prescribe those as well. Disability then. I said earlier that disability is related mainly to the level of consciousness. So what are some of the main causes of diminished level of consciousness? Profound dyspnea, in other words, very short of breath, a fall, head injury, hypoxia, faint, stroke, epilepsy, hypoglycemia. How do we assess level of consciousness? Another mnemonic that you can use that is very straightforward is aged, AGED. The age, the A bit stands for AVPU. And AVPU is really a mini Glasgow coma scale that you can use very quickly and decide whether you need to put somebody onto a Glasgow coma scale chart. So AVPU stands for alert. So when you speak to your patient, are they alert? Is A. V, are they only alert to your voice? P, are they only alert to a painful stimuli? And U, are they unresponsive? Obviously, if it's the latter two, pain or unresponsive, then you need to get help very quickly indeed. So you can decide whether they need to go onto a Glasgow coma scale then. G stands for glucose. Is it appropriate to check a blood sugar? If their blood sugar is very low or very high, then we need to get medical help and use the appropriate interventions for that. As I said earlier, if it's an elderly person, we're happier for their blood sugar to run slightly higher, around the 7s, than somebody that's maybe a bit younger. E stands for eyes. What do their eyes look like? Are they equal? Are they responding to light? D stands for drugs. And that's not just some that they may have ingested before they've come in to see you, but what's on their medicine chart? Have they been started on something new? What's happening there as far as medication goes? So what do you do if you think that there is a problem with a level of consciousness? Put them onto the Glasgow Coma Scale, get your help, as we said earlier. Keep recording their vital signs and get your help there as soon as you possibly can. And also bear in mind that we need to assess our patient for pain, and sometimes things like the Abbey Pain Scale can be useful for that. E then stands for exposure. And exposure basically means that we need to check the patient from head to toe. We need to make sure as well, if we are fully exposing the patient, that their dignity is maintained. But we're starting at the top and we're trying to put a picture together of what's going on here with our patient and make sure that we don't miss anything out. So it gives us a full picture of what's happening. So start up with your face. Is there any droop or signs of any paralysis? Is their chest rising and falling equally? Are they breathing all right? Have they got a rash over their chest or their abdomen? Is their abdomen tender? Is it swollen? Have they got good strength in their limbs or normal limb strength? And you can ask them to try and push against your hands or lift their arms up and lift a leg at a time. Have they got a swollen, tender calf? Anything that will give you a bit more information about what's happening with your patient. And also any additional information, remember to check the notes. Look and see what's been happening with your patient. Look and see what medications they're on. Have they been started on anything else, anything new? So that's your A, B, C, D and E. That's what we use to do a systematic assessment of our patient, and we use it along with SBAR to hand over information on our patients as well. So it keeps us systematic, it keeps us objective, and it makes sure that we don't forget about anything. And just in summary, if a patient is deteriorating, it is important to pick this up as soon as possible. Make sure that we don't miss it. Use your systematic assessment, your A, B, C, D and E, airway, breathing, circulation, disability and exposure. Use the appropriate pathway to get your experienced help that you need. Use an appropriate communication tool like SBAR so that the seriousness of the situation is communicated properly. And think about what chart you're using to maybe track what's happening with your patient and show you trends and trigger alerts. Thank you.